Hey Guru Nation, welcome back to theclinicaltrialsguru.com. So I wanted to talk to you about sub-investigators and other personnel that you add on to your clinic. So we're actually doing another module, we're redoing another module for our Site Owner Academy. So that's a shameless plug for anyone interested in starting a clinic. We have an academy for you called the Site Owner Academy. But sub-investigators, almost nobody talks about except me, and it's because everyone's focused on the PI and the coordinator and the CRA and the FDA. Sub-Is are the unlock to everything that you do in your clinic, okay? You need more patients, you need more oversight, you need someone to do a certain assessment, you need more credibility to your clinic in general. You bring on a sub-I. They could be another MD, they could be a DO, they could be a nurse practitioner. I love nurse practitioners. They could be a physician's assistant. I also love physician's assistants. But nurse practitioners are almost the best option because they can operate without strict supervision of an MD. They still have to get supervised by an MD, but they have much more freedom and flexibility as opposed to a physician's assistant. But I love physician's assistant too. The point is not to compare an NP and a PA. They're all good. Everything I mentioned is good to be a sub-I to add to your clinic. Why would you want to add them to your clinic? Well, many protocols require multiple clinicians, right? Not all of them, but some do. They say in addition to your PI, who's going to be a sub-I and what are their qualifications? It'd be nice to have a couple MDs, a couple DOs, a couple NPs, a couple PAs to add to the 1572. Not too many. You actually want the people that you're adding on to the study to actually do something with the study, do something of value. Otherwise, it could be looked at as a referral fee, and those are illegal. You can't just pay someone to refer patients to you and give them a referral fee. That's illegal. What you can do is compensate your sub-investigators accordingly to what's considered fair market value for what they're doing in the study, right? So you can actually have them do assessments, you can actually have them pre-screen patients, you can actually have them provide backup oversight when the PI is missing, or provide oversight in many visits when the PI is not there, and they can actually conduct the visits, and then the PI just needs to have oversight. So bringing a sub-investigator on also grooms these people to be your PIs if they're the MDs. An NP and a PA can never be a PI in most cases, but another MD or DO can. So that's a great way to groom your next PIs, right? That's how you bring in the pipeline of clinicians to be your next PIs, because you can't just rely on one PI forever. So if you have a research clinic and it's a standalone research clinic that's not associated with any medical practice, I would strongly advise you to look for a nurse practitioner or a doctor to set up shop in your private practice or in your clinic and have them set up their own private practice, even if they're not going to be your PI. But they could be your PI, but even if they're not, if they're willing to be a sub-I and conduct some assessments and allow you to recruit some of their patients, you can compensate them. You can also give them free rent or a discount on their rent or work out a deal with them because they're going to be helping you out with the research. It works well. Nurse practitioners are my favorite, but also PAs, and everyone needs more MDs. So keep going out there, recruiting more sub-Is, and we'll talk to you all later. Take care.